you for joining me for this podcast. My name is Louise. I live in Israel and work at the Innovation Center of Denmark in Tel Aviv. I specialize in health, life science, innovation. And on my podcast, Healthy Innovations, I explore new, hot, interesting, relevant topics within these fields. So chronic diseases have become a great challenge on global health and a substantial burden on our healthcare systems. Not only is the number of chronic patients growing, but chronic patients, due to improved treatments, also live longer with their illnesses and therefore require more services during their lifetime. And today I want to focus on diabetes as one of the main chronic diseases where we see really an increase in the number of people being affected. So in Israel, I think the prevalence rate is around 9%, but Sivan, you can correct me if that's wrong. And in Denmark, it's around 6%. And it's growing, and it's actually doubled since 1996. And in many countries, we particularly see an increase in the number of children being affected by diabetes. And therefore, the topic of obesity is also something that's very much in focus because it's one of the main causes of diabetes. And also because recently we had the launch of the new drug, Wegovy. And another important point to make, I think, is that diabetes is not evenly distributed, so to speak, in our societies. We see a prevalence of the number of diabetic patients in more rural area and low-income area, where also the level of education is lower, and the financial means to live a healthy lifestyle is lower. And we know that living healthy today is not cheap. And so I think there's a lot of room and need for more effective and targeted and urgent innovation and interventions within diabetes and also within obesity. And so actually at the Innovation Center in Tel Aviv, we've launched together with great partners in both Denmark and Israel a task force on chronic diseases with really the purpose of establishing joint research and innovation projects between clinicians, researchers, and other stakeholders from our two countries, in order to try and have better solutions for prevention, treatment, and management of diabetes and other chronic diseases. And we actually decided this year to start the focus with diabetes and obesity. And so if there are also any clinicians and researchers and other stakeholders involved in diabetes and obesity who would be interested in joining our task force, you're also very welcome to reach out to me. And one of our partners on this task force is the Sphere Diabetes Program in Israel. And so today I invited Dr. Sivan Spitzer, who's the Deputy Director of the program, to come and have a chat with me about diabetes and obesity and how we can try and prevent this number from continuing to increase, and also how we can try and improve the quality of life of those that do suffer from these illnesses. So thank you so much for joining me today.
Thank you for inviting me.
And even on an election day in Israel, because today is actually municipal elections, so everybody's actually off. So I really appreciate you taking the time.
Thank you. It's a pleasure to be here.
But before we dig into the issue of diabetes, maybe just say a few words about yourself.
Sure. So I am a member of the Azrieli faculty, a faculty member of the Azrieli Faculty of Medicine of Bar-Ilan University, which very interestingly was set up far from the main campus, which is located in the center of Israel, in the Ramat Gan area. The Faculty of Medicine was set up north in Israel's northern social geographic periphery, which is the Galil region, with the idea that it will be a major economic change engine for the region. there is a major shortage of physicians in the region. It has the lowest rate of physicians per 1,000 people in the country, the Galil region. So the Faculty of Medicine was set up in the north really to see how it can bring innovation, it can improve the health infrastructure of the region, it can train new physicians. And I am not a medic by background. I'm an organizational sociologist, and my research focus is on reducing health inequity, focusing really on where the intricacies of medicine and society meet. And how can we, and we'll talk a little bit about more, but we tend to focus a lot on the healthcare system, when there's so much more that actually affects, people's health. So what do we need to do, and what are really the complexities in making sure that people can attain their best health, which is health equity.
And what is the Sphere Diabetes program?
So,
just say a few words about that.
So Sphere was launched in November 2021, and it's actually an acronym, Sphere, for Social Precision Medicine Health Equity Research Endeavor, with a specific focus on diabetes and obesity. And the reason is that when we look at the prevalence of diabetes in the north compared to any other region in the country, it's significantly higher. We also see, if we see more or less a plateau of the increased rate of diabetes in the country in Israel over the last 3 years, in the Galil region in the north, we see an increase of over 12%. So by all accounts, we're talking about a hotspot which we see a major growth in chronic disease. We also see, of course, a major rise in obesity. And the thought behind Sphere was, as a faculty of medicine situated in the north, how are we accountable for our community's health? Where can we bring in the research, the innovation, the knowledge and skills that we have to intervene in the real world and really be part of the communities so that we can participate in tackling this wicked problem of diabetes and obesity? So we launched Sphere in 2021, November 2021. We started with intervening with or working with 5 towns. Today, we're working with 17, also with a partner of the Ministry of Health, so it's become a national program, and due to expand to over 25 towns by the end of 2024. So, and about almost 700,000 people. So, quite a big program.
Maybe you can just say a few words about the diabetes crisis. Sorry, my voice today. The diabetes crisis that we're facing.
So I think if I have to relate to the diabetes crisis, I would actually start with the question, what affects our health? And a lot of times when we look at multiple chronic conditions, we tend to think, well, maybe it's a question of the quality of care or our access to care. And that's why we see a rise in diabetes. But actually, and diabetes is a really good example of what we'll be discussing, because a lot of the factors that contribute to the increased growth in diabetes or the increased prevalence of diabetes is actually what we call the social determinants of health. So when we look at what affects people's health, health systems account only for about 20% of the outcomes. And more than 50% are actually a direct outcome of where people live or their zip code. So the zip code actually has much more effect than the genetic code. And so when we look at why we see a growth in the diabetes epidemic, we have to look at what is in our surrounding. Do we have places to exercise? Do we have access to healthy foods and vegetables? Do we have the knowledge to really take care of ourselves, but also the infrastructure to do so? And so you start asking questions, and when you look at communities, and you said that this earlier, Louise, the relationship or the correlation between poverty and diabetes or poverty and obesity, when we look at the level of health education and diabetes or early onset of diabetes. In the Galil, we have families who are 2nd and 3rd generation diabetics. So how do we break this vicious cycle, and why do we keep seeing it? And for Sphere and for myself, we think the answer is not only in healthcare, and that we have to create a new language around integration of care between the community and health. And it
Right.
requires innovation both in the language that we speak, to make sure that we speak a common language of organizations that often work in their own silos and don't always take ownership. Health is, unlike Denmark, health is not provided through the municipal services,
Right.
but it's on its own. You need to create a common ground. So how do we do that?
And it's still also surprising to me because both Israel and Denmark and many other countries where diabetes is spiking are considered high-income countries. Even the low-income groups are high-income compared to many other countries. And still we see that it affects so greatly our health
Well, we
in
see
certain areas like
that's
diabetes
true.
and obesity.
Yes, and multiple chronic diseases.
Yeah.
And then we see also the complications such as end-stage renal disease.
Exactly.
But we also have to account, at least in Israel, for the differences we see in terms of, the disparities of socioeconomic income between the highest percentile to the lowest. I have to say we're not in such a good place compared to, other countries or Denmark. And so it's not that surprising, I have to say, unfortunately, that we see some of these rising chronic diseases in these populations.
Yeah. And what would you say are some of the challenges that are standing in our way of improving this? It could be technology or policy or education or...
So I would say, diabetes, as I said earlier, is a wicked problem. It means that it encompasses both kind of all of the above that you just said, right? So it's a social problem as much as it is a health problem.
Yeah.
And so to really kind of untangle this very complex issue, we actually have to work with all of the above, right? So we have to think, what are the technological disparities that we see in terms of, as I said, for example, in the north, we have the lowest rate of physicians per population.
Right.
Do we need to think of innovation around remote care
Yeah.
specialists? Do we need to upgrade the system by having other tools, not just like remote care, but maybe allow family physicians to make better conscious decisions in terms of the community, policies that would support health, infrastructure. So education that comes in, of course.
Yeah.
So it's all of the above, and that means you have to think of how do you put the pieces of the puzzle together, which make it very complex. But it requires us to think a lot more transdisciplinary,
Right.
and know that to reach the distal outcomes that we want to see in terms of reducing, if it's in diabetes, the HbA1c levels, to make sure people are well maintained or their disease is well managed. To reach those distal outcomes, we have a long journey ahead to push the needle, which really needs us or requires us to encompass a much wider view of the problem than we've had to date.
I also think one of the main focus areas needs to be on education. And that's a difficult one. Because it's sometimes, if we're talking prevention and not already people who are affected, but we want to prevent people from being affected, it's sometimes difficult to make these changes if you don't feel that you are ill.
Yeah, ill.
And I know that, for example, in Israel, the Ministry of Health has tried with the labeling of food to kind of educate people what's the right choice of food. But I'm not sure that the result has been so great. And there's also a question of where does the education need to take place, and do schools need to take part in that? Does there need to actually be education around healthy lifestyles as a topic in school, or is it something that's done at home by parents? Or how do we increase that preventional initiative?
So we know. So I would say again, it's a multi-component education initiative. So on one hand, if first of all to relate to your kind of question around prevention, we know that every year 6 to 8% of pre-diabetics will transition and become diabetic.
Which is high.
Which is very high.
Yeah.
How do we make sure that we identify them?
Mm-hmm.
Prediabetes is not a clinical condition,
No.
but it's that point of time where we can intervene to make sure that they don't become diabetic and transition. So how do we educate within the healthcare system
Mm-hmm.
to make sure that this is a quality indicator, that family physicians are monitoring those at risk, that we're able to intervene early on where we can still talk about reversing the onset of diabetes, or at
Mm-hmm.
least making sure that there's a sort of remission, or we buy more time before people become sick.
Right.
So one way of educating is educating family physicians to become diabetologists.
Yeah.
That's one kind of education, or making sure that we have, as I said, positive monitoring. So it's not only if a person was given the right medication, but are we making sure that we're monitoring them over time? Are we intervening?
Mm-hmm.
Within the school systems, in Israel, we have had a national program for healthy lifestyle within schools, or health promoting schools. However, it's not monitored. So schools are given a very low kind of yearly budget, which is about 3,000 shekels, which is really non-significant.
Right. Yeah.
But there's no evaluation of cost effectiveness. What can we make sure to show a difference in education?
Right.
So what happens is, we shouldn't be surprised when we look at cities, some of the cities I work with, for example, like Shfa'am or Sakhnin or even Tzfat. 40% of children in 7th grade are already overweight or obese, which is a huge, a really high rate of children. So what does it mean, education in school? And how can we make sure that it's not only educating or giving them the information, but also making sure that we can demonstrate action? Because changing our lifestyle is not only education, it's reaching that. So, for example, we're working on strategic plans where, if we're working with girls in the 7th grade, do we have the equipment, if they're religious, for example, do they have equipment in schools to make sure that it's part of their program? So they're studying about health, and, for example, it's inserted into biology lessons as well, right? So what are the effects? A little bit different just than what kind of sandwich do we bring to school? But then they also have the infrastructure, so it's tied. So we study, we understand the processes, and then we also act. And to make that connection in all levels, so you have policy in place, and the policy is implemented, and the implementation leads to actions, whether it's education or behavioral change. It's often a road that we don't think of offhand. And that's part of the work that we are now doing across towns, to create long-term plans where things are tied together. And then it's also backed by community action. So what are the community infrastructures to create, again, similar pathway, so that we create a culture where we have policies in place, we make sure they're implemented, and then we have the education and action, or behavioral change action, to make sure that we see a widespread change.
Do you also then have more collaboration, for example, between hospitals or the general physician and the municipalities to kind of link the healthcare part with the social part?
So yes, that's one of the biggest challenges. So I would say less with hospital, because in terms of chronic disease like diabetes and obesity, it's managed in primary care. So a lot of the sphere work is actually done with the HMOs. We partner with all of them. Partnering means that they actually are part of the leading team of sphere, so it's not only on paper or in theory. The idea was we all have the same kind of pains from seeing this happen. It started with the region, creating a regional ecosystem where we can work together. So we partner with them, and that's how we bring together. And I said it's a platform where, on one hand, we work within healthcare systems. So an example is setting up obesity clinics across the Galil with our partner HMOs, so that we can give treatment to those who need. On the other hand, it's working with the municipal system. But then the real innovation is creating the integration between the two. For example, in a mobile unit that we have, where we are able to work with the municipalities and with the HMOs to be able to create one-stop shops for diabetics to do their annual exams. So instead of one day going to a physician to do their eye exam or blood work or sometimes it takes 3 to 5 days.
Yeah.
Working together, we're able to bring this to those who need it the most to make sure that they are on top and compliant to their care regimen, and that's a way of bringing partners together.
Mm-hmm. So I think that's already one example of how to think innovative.
Mm-hmm.
But what are the innovation trends that you are seeing within diabetes? Mostly maybe in terms of helping those that are already living with diabetes to try and increase their quality of life and make it easier. Because we also know that many have a tendency maybe not to adhere to their treatment plans or the lifestyle that it requires.
Right.
And if they're already in a rural area, maybe not to then also go to their physicians to get the help they need.
Mm-hmm.
So what kind of innovation trends are we seeing to maybe help these people make it part of their life now?
Part of their lives.
Yeah.
So I think, at least from my kind of expertise, what we look at our social technological innovations, and how can we bring them together, understanding really the inequities that we see. So I'll give an example. There's very, very good medication that exists today to prevent complications of diabetes for those who are already sick.
Yeah.
And they're in Israel, they're financed, they're part of the health basket. Israel has one of the best health baskets for diabetics in Western countries. However, when we look at the number of patients who receive the medications in the north compared to the center, we see a 30% disparity. And the question is why?
Yeah.
So on one hand, it could be the patients. The patients don't know their rights and therefore don't know, that they're entitled to these medications. However, I would not expect an average person to know what are the new medications out there.
No.
So one way is to, of course, educate patients and give them, information in plain language. On the other hand, reducing this disparity is as much a responsibility of the healthcare professionals.
Right.
And when we saw one of the reasons for disparities was the lack of family physicians' knowledge to write the prescription correctly. So a lot of times, in filling in the information needed, if it was not filled in correctly, they would receive from the HMO that this cannot be funded. It's not prescribed correctly to the patient. And so, and there's not what we call positive monitoring. So if I'm, as a physician, would prescribe a medication that a patient is not entitled to, the HMO will ask, well, why is this being prescribed? If I'm not prescribing a medication he should be receiving, no one is asking.
Yeah.
So how can we make sure, first of all, that this is an indicator that comes into play, that we have the positive screening just as much as the negative? And the other thing that we did is create a simple calculator, which is an app for family physicians where they can put in the patient's data and therefore get the recommended prescription for the new medications. So that's kind of a social technological innovation, which is sometimes very simple, but it's to make sure that we overcome those barriers.
Exactly. And I think actually also the point of positive monitoring is very important, because I do find that even in our well-developed healthcare systems that we have both in Denmark and Israel that are public, so basically you should have access to whatever you have the right to receive, and there should be a solution for every challenge that you face. A lot is still, I feel, put on the patient themselves.
That's right.
To make sure they get what they need and to follow up, because the system doesn't automatically say, hey, here's somebody that should be doing this or receiving this. It's up to the patient to approach and make sure you follow up. Nobody's going to call you in for a follow-up. Okay. So there may also be some innovation that could be done in the way that the system is set up.
That's right.
To make things more automatic if we already know what the patient needs.
Right. And in a way, it's taking the knowledge we have around precision medicine and making it personalized.
Exactly.
Right? We want to aspire to reach that level where medicine is personalized, and we have to understand the living environment, and that's part of what we try to look at. And what are the social technical innovations, I would say, that we can bring in. So that was that's what we try to do.
Yeah. So maybe just to round off, I always like to kind of finish by looking into the future. to maybe find some encouragement. If you look 10, 15 years from now, what would you think would be the best examples of how innovation has helped us prevent or treat diabetes, obesity, and the comorbidities of these chronic illnesses?
I hope that 10 to 15 years from now, we'll have much more knowledge on how to tackle some of those distal metrics that we don't often take into account.
Yeah.
I think, the new medications like Wegovy or like Ozempic bring a lot of innovation, but we have to make sure that they reach the populations that need them the most.
Right.
And so I'm hoping that through complex real-world interventions, really sinking in the mud, within 10 to 15 years, we'll have a better idea of what is the roadmap to really reduce those inequities that we see between populations.
Right.
That would be my hope, at least, looking into the future.
And maybe also reduce actually the number of people who to really do proper prevention.
Yes.
Because it is something that can be prevented.
Oh,
that's the most
definitely.
kind of
definitely, which is
important and frustrating
exactly.
thing at these times is that you can actually, in many cases, prevent diabetes.
That's right.
Great. So thank you so much for joining me.
Thank you for inviting me.
It's been really inspiring, and I think there's still a lot to talk about and a lot to do in this field. And I'm really impressed at what you guys are doing and kind of taking the community view on this as a societal issue, not just, as you said, as something that the healthcare system needs to deal with. Thank you to all of you for listening and watching, and I hope to see you next time.